place in this section, if you remember, the endocrine system glands. Let me just do a quickie review. So what other organ system is the endocrine system kind of like? Nervous system. Who sends signals faster? Nervous sends them faster. Who has effects that last longer?
Endocrine.
Endocrine, good. How does the endocrine system send its signals? Using hormones. Hormones are basically chemical messengers. Classifying hormones, one way to classify it is based on where they act. Hormones that affect either nearby cells or sometimes the cell that released it, those type of hormones are called what kind of hormones? Those are local hormones. And remember, what's it called if the hormone actually affects the cell that just released it? Autocrine hormone. If it affects nearby cells, it's called paracrine hormone. Good. And then we kind of left those behind. We're not really going to talk about the local hormones so much. Our focus was on the ones that you put into the blood and then they travel some big distance. What are those hormones called? Circulating hormones. All right, good. Another way to classify hormones is based on their solubility. What's the two categories based on solubility? Lipid soluble and water soluble. Good. That solubility will also influence where you find the receptors for those hormones. Where do you find the receptors for lipid soluble hormones usually? Yeah. In the nucleus of the cells, right? Lipid soluble hormones can easily pass through the cell membrane. They can pass through the nuclear envelope, and so they have their receptors inside of usually the nucleus, right? Where do you find the receptors for water soluble hormones?
Outside of the outside.
Yeah, outside of the cell, on the surface of the cell, right? Why is that?
They have their permeability.
Yeah, they can't get in, right? They can't pass through the cell membrane, so they have to attach to these receptors that are on the outside. However, when they do attach to the receptors on the outside, what does that cause to form on the inside? Something
Like
called
secondary messenger?
a second messenger. Yeah, and then the second messenger will go out doing things. All right, that was pretty good. Endocrine system glands. We didn't get too far into this. Basically, we just talked about two. What gland is considered the master gland?
Hypothalamus.
Hypothalamus is considered the master gland because it controls the pituitary, and then the pituitary controls everything else. Let's talk about the pituitary. There's two parts to the pituitary. What's the bigger part of the pituitary called?
Anterior.
Anterior, and then there's the posterior. Corey, you don't have to keep raising your hand. You're so much more polite than these animals over here. They're just like, yeah, it's nice, but these animals, you know, they're just. Corey's like, this is a respectful gentleman over here. You guys are like, anyway, yeah, anterior and posterior. How many hormones in the anterior pituitary? 7. How many in the posterior pituitary? 2. Okay. Somebody said 5. I think who said 5? Did you say?
We're talking about cells, probably.
You're either talking about cells or you're talking about the number of hypothalamic releasing hormones that are responsible for the 7 anterior pituitary, right? So remember, the anterior pituitary, you got to have hormones come from the hypothalamus down through this little blood vessel network and tell the anterior pituitary release its hormones. Posterior pituitary, how's the connection made with the posterior pituitary? It's a lot simpler.
Two terminals?
What does that mean?
It's already there.
It's already, it's a direct neuron connection, right? You got neurons that really start up in the hypothalamus and then they actually connect and go down into the posterior pituitary. So it's a lot more straightforward. All right. All right, I think that's enough review. Any questions about any of that stuff? That was from Tuesday. All right, so we're going to take off in the endocrine system gland section, and I think we're going to start with the thyroid. All right, so thyroid, if you feel your neck and you feel like where your Adam's apple is, that's your larynx. It's made up of this big pieces of cartilage we'll talk about later. But if you go just like a centimeter or 2 below that, that's roughly where the thyroid is. You know, if you have like a thin neck or whatever, you might be able to feel it a little bit. It can be a little tough to feel. If you've got an enlarged thyroid for any reason, you can usually feel that. The thyroid has 2 lobes and then a connection in the middle called the isthmus, which makes it kind of look like a butterfly. If you did a tissue sample of the thyroid and cut into it, you would see basically something that looks like this. And there'd be lots of these things. These are called thyroid follicles, and the thyroid is filled up. They're like little sacs, little round sacs that are all over the thyroid. And inside of each of those is this material called colloid. All right, so the whole round circular thing would be called a thyroid follicle. The material on the inside is called colloid. Colloid is really the stored form of hormone. Okay, the thyroid is unique in that it actually stores up its hormone, and then it can take the hormone out of storage when it needs to and release it into the blood. Most other endocrine glands don't do that. Most other endocrine glands, they kind of make it on the spot. It's like, oh, you want some hormone? All right, hold on, let me make it for you. The thyroid's like, hold on, I got it in storage, let me just get it out for you, okay? Now, in terms of your so-called thyroid hormones, there's two of them, T3 and T4, okay? What does the number refer to?
Iodine.
How many iodines are attached? You absolutely need to have iodine in your diet if you want to make T3 and T4, okay? Remember, you don't need a lot of it in your diet. You may remember from the chemistry chapter in A&P1, what's it called when you have an element that you don't need a lot of, but you do need some? That's a trace element, right? And iodine's a good example of a trace element. You don't need a lot, but you do need some in order to make these thyroid hormones, okay? One thing to tell you is that if I ask you, or if you're in the hospital and somebody's referring to the thyroid hormone levels on a patient, they are referring to levels of T3 and T4. That's what they mean when they say thyroid hormone levels. However, are those the only hormones that come from the thyroid? No, don't be tricked. There is another hormone that we'll talk about called calcitonin, and that also comes from the thyroid. It's just that in like common, nurse and doctor speak at the hospital, when they say thyroid hormone, they're referring to T3 and T4. Okay. So what does T3 and T4 do? What are the actions of the thyroid hormone? Really to increase the rate at which your body cells undergo chemical reactions, the rate that they burn glucose and they make ATP, okay? So it really jacks up what's called the basal metabolic rate, makes it a lot faster. It stimulates the synthesis of the sodium-potassium pump, which is also known as the sodium-potassium ATPase. Remember, we talked about the sodium-potassium pump a lot when we talked about the nervous system in A&P1, but the truth is all body cells have this little pump, and by increasing the synthesis of this, it creates more usage of this particular pump, and as this pump's being used, it actually generates some heat. So there is a slight rise in body temperature as T3 and T4 levels go up, simply by increasing the activity of chemical reactions throughout the body, as well as increasing the activity of this pump. All of those things have kind of this heat-producing effect. Other stuff to know about thyroid hormone, it's an anabolic hormone. It promotes protein synthesis. It also stimulates lipolysis. What's lipolysis?
Burning of fat.
Yeah, breakdown of fat. So this is why if you see somebody that's hyperthyroid, right, that has high levels of T3 and T4, what does their body shape usually look like?
Skinny.
Yeah, they're relatively skinny, right? When you increase the rate that your body cells burn calories and you're promoting fat breakdown, all those things are going to kind of lead to like a thin body shape. Versus if you're hypothyroid and you have low levels of T3 and T4, you slow down your metabolic rate. You slow down fat breakdown, and those people tend to be, overweight. Another thing to know about thyroid hormone is they actually enhance the effects of other hormones like epinephrine and norepinephrine. These two guys anyone know where these two guys come from? What gland? Yeah, the adrenal gland. Specifically, what part of the adrenal? The medulla. Good. They come from the adrenal medulla. They're a big part of your fight or flight response. Okay, when you turn on your sympathetic system, you turn on the adrenal medulla and you release lots of epinephrine and norepinephrine. And these chemicals can increase your heart rate. They can increase constriction of your blood vessels. But the interesting thing about both epinephrine and norepinephrine is they work better if you also have some T3 and T4 around. So there's an enhancement effect for those hormones if you have some T3 and T4 around as well. Accelerate body growth. especially of the nervous and the skeletal system. So when you're a fetus or an embryo, anyone remember when they were a fetus or an embryo? All right, me neither. But anyway, when you're a fetus or an embryo, your nervous system is developing, right? And in order for it to develop properly, you got to have normal levels of T3 and T4. It's really critical that during development, your T3 and T4 levels are normal, just so your nervous system develops properly. This is just showing you how thyroid hormone secretion is controlled. It's basically a negative feedback system, right? So, you start up here, and remember, like so much of the hormones that we're going to talk about in this chapter, it's a pain in the butt because one hormone leads to the release of another hormone, which then releases another one. So you start up here at number 1. Let's suppose that your blood levels of T3 and T4 were starting to run low, or let's suppose that metabolic rates were low throughout the body. Those might be triggers that would then cause the hypothalamus to produce TRH. TRH stands for thyrotropin releasing hormone, and it's going to travel down through that little blood vessel network. Anyone remember the name of that blood vessel network that connects the hypothalamus with the anterior pituitary? What'd you say?
Is it with an
Something
acid?
artery.
What'd you say?
Something artery?
It's like Philipillis or something.
Philobillas?
I don't know, I'm making it up.
I think we're all speaking
Figuring it out.
gibberish.
I think that's a drinking buddy, Philobillas or something. I don't know. Anyway, what it is it's called the hypophyseal portal system. It's just a little blood vessel network. It carries the TRH down to the anterior pituitary. TRH, again, stands for thyrotropin releasing hormone, and that's because another name for TSH is simply thyrotropin. So thyrotropin releasing hormone is causing the release of thyrotropin, otherwise known as TSH. TSH stands for thyroid stimulating hormone. That guy then travels down to the thyroid itself and causes the thyroid follicle to release some T3 and T4 into the blood. Okay? Once those levels start to build up, they're able to go back, and the red dotted line means they're going to have an inhibitory effect. They're basically going to go back up and shut off the release of not just TSH, but actually go all the way up and shut off the release of TRH. Okay? So it's a negative feedback system that's kind of controlling those levels. And that negative feedback system we're going to talk about in a second is really important. It's really important to have the ability to shut that system off, and I'm going to show you what happens when you don't shut it off in a second. Before I do that, though, I just want to mention calcitonin. So calcitonin is the hormone. It probably doesn't get the fanfare that T3 and T4 do. It's not, when you're at the hospital and someone says thyroid hormone levels, they're not usually referring to calcitonin. However, it does come from the thyroid. It comes from a bunch of cells that are outside of the follicles. Okay, they're known as parafollicular cells. So if you go back to this colloid junk that's in the middle, that's the stored up form of T3 and T4. Okay, but the calcitonin is coming from cells that are actually outside of the follicle called parafollicular cells. They produce the calcitonin. Calcitonin does not affect your basal metabolic rate per se. Calcitonin, its effect is to reduce blood calcium levels. And the memory trick for it, it's kind of a dumb memory trick, is calcitonin tones down blood calcium levels. It reduces blood calcium levels. How does it do that? Well, it does it actually in 2 ways. You can write this in because I don't think it's listed up here. It does 2 things at the same time. It blocks osteoclasts and it stimulates osteoblasts. So it blocks osteoclasts and it stimulates osteoblasts. What did going back to AMP1, what do osteoclasts do?
Break down bone.
They break down bone. What do osteoblasts do?
Build up
They build
bone.
bone. So here's how this works. This is how this lowers blood calcium levels. If you stimulate the osteoblasts to build bone, in order to build bone, they need calcium. So what they will do is they will take the calcium out of the blood, which will reduce blood calcium levels, and they'll put that into the bone. And just as an added measure, you block the effects of osteoclasts because you don't want them basically working against the osteoblasts at the same time. Okay? So stimulate the osteoblasts, block the osteoclasts, and that will reduce blood calcium levels. Okay? Does that make sense how that mechanism works? Okay. Now, the antagonistic hormone to calcitonin is parathyroid hormone, and I'll go through that here in a moment when we talk about the parathyroid gland. So just put that on hold for a second. But first, let me talk to you about a problem called goiter. First thing you should know about goiter, it simply means an enlargement of the thyroid gland. It's not a diagnosis, it's a sign that you would detect on the physical exam. You don't really, in other words, if you see a goiter, you don't really know what's causing it. You'd have to do further tests on the person to try to discover that. You might find a person with a goiter that's hyperthyroid. Again, what does hyperthyroid mean? If you're hyperthyroid, you have high levels of T3 and T4. So you might find a person with a goiter that has hyperthyroidism. You might find a person with a goiter that has hypothyroidism. What does that mean? Low levels of T3 and T4. And then here's a word maybe you haven't heard before. You might find one with euthyroidism. What does that mean? That means normal levels, right? They have normal levels of T3 and T4. So you'd have to run different diagnostic tests, maybe take a biopsy of the thyroid tissue itself, measure also TSH levels and TRH levels, and maybe then you could kind of tease out what the diagnosis is. Now, if you're in a third world country, okay, Norwalk doesn't classify, but if you were in a third world country and you saw somebody with a goiter like this woman, there would be a good bet that it's probably due to not having enough iodine in their diet. Okay, so that would be a goiter with hypothyroidism, because remember, if you do not have iodine, you can't make T3 and T4, okay? End of story. You can't make T3 and T4. Now, how does that problem of not having iodine actually lead to this enlarged thyroid? And that's what I wanted to tell you about by going back to this diagram. So, if you don't have iodine, you are never going to make T3 and T4. And if you never make T3 and T4, you're never going to have this dotted inhibitory red lines. So in a person that has an iodine deficiency, they are just blasting through the green line constantly. TRH to TSH, and then trying to make T3 and T4. But what happens is, and another piece of the puzzle that you need to know is that TSH, thyroid stimulating hormone, when it goes to the thyroid, when the thyroid's unable to use iodine to actually make T3 and T4, TSH has a growth effect on the thyroid tissue and will actually make it get larger. So you just keep hitting that thyroid with more and more TSH. The thyroid's like, what are you doing? I don't have any iodine. I can't do anything. It's like, I don't care. I'm just here. Try to make it. And it's like, I can't. And it's like, this just keeps hitting them. That thyroid tissue is just going to grow and grow and grow. Okay? So that's the pathology, or that's the pathogenesis of how that sort of leads to that enlargement that you see. Yeah.
And after prescribing levothyroxine, is it to help you make?
Yeah, it's like a synthetic form of T3 and T4. So if you have hypothyroidism, they might put you on levothyroxine or Synthroid or something like that just to replace the T3 and T4. Yeah. Now, sitting on the back of the thyroid are the parathyroid glands, and there's usually 4 of them. Usually 2 in each lobe. I can tell you that, real human, they don't look they don't look like these nice green little dots that's really easy to distinguish from the rest of the thyroid. They kind of blend in, and it can be hard to identify them sometimes, so they don't just show up all nice and neat like that. If you did a tissue sample of the parathyroid, you would see a lot of these small dark purple cells that are called chief cells, or they're also known as like dense principal cells. They go by a couple of different names, but these are the guys that actually make the parathyroid hormone. Parathyroid hormone is the antagonistic hormone to calcitonin. So calcitonin reduces blood calcium levels, and parathyroid hormone increases blood calcium levels. So again, the memory trick, which is kind of a stupid memory trick, but it works, is just remember that calcitonin tones down blood calcium levels, and then you just got to remember PTH does the opposite. I know it's not a cool memory trick, but it works. How PTH works is kind of the exact opposite of calcitonin, but it's a little bit more complicated because it does a couple of things. So first of all, it basically works the opposite way of calcitonin in that it's going to turn, and you can add this over here because it's not listed, but it's going to turn on the osteoclasts, and it's going to turn off the osteoblasts. And if you think about it again, what do osteoblasts do? Build. What do osteoclasts do? Break down. If you are turning on the osteoclasts, they're going to be breaking down the bone, and that calcium that was inside the bone is going to go into the blood, and that's going to raise blood calcium levels. Okay? So that is one way that parathyroid hormone raises blood calcium levels, but there's actually two more ways that also help. Another way is that PTH goes to your kidneys, and it tells your kidneys not to get rid of any calcium in the urine. It promotes what's called calcium reabsorption. We'll talk about this, in a couple of months when we talk about the urinary system. But the kidneys are in charge of deciding what you keep in your body and what you get rid of in the urine. If PTH is around, it tells the kidneys, don't get rid of any calcium. Please keep the calcium inside our body. So that's going to help you to at least maintain your blood calcium levels, which then also helps ultimately to help raise them with some of these other mechanisms that are going on here. And then the third thing that it does to raise blood calcium levels is it goes to the kidneys again and tells the kidneys to make the active form of vitamin D, which is called calcitriol. Now, going back to AMP1, where did vitamin D synthesis begin in the body? The skin, right? It begins in the skin. But that's not the final version of vitamin D that you get in the skin. Okay, that's not the active version of vitamin D. What actually has to happen is after you have that preliminary version, it has to then go to the liver, it gets converted into something else, and then finally the vitamin D goes to the kidneys and it gets made into this active form that's called calcitriol. And if you have parathyroid hormone around, it enhances that step. It accelerates the rate at which you make the active form of vitamin D. So what? How does that lead to increased blood calcium levels? Well, once you have the active form of vitamin D, it goes to your intestines and helps you absorb calcium from the foods that you eat. Okay? So, you can have a diet that's really high in calcium, but if you don't have enough of the active form of vitamin D in your body, you'll just poop that out in your stool and you won't absorb the calcium into your system. So having more of the active form of vitamin D leads to more calcium absorption by your intestines, which also helps to raise blood calcium levels. So all three of these mechanisms are working toward the goal of raising your blood calcium levels. Okay? This is just another one of those diagrams showing you the control of this. So let's suppose you start here at number 1 and you've got a high level of calcium in your blood. I don't know, today was the day you decided to, chug like 6 liters of milk. I don't know, whatever. You've got like a high level of calcium in your blood. Your body's like, oh my God, that's too high. I know, let's have the thyroid release calcitonin. And then through those mechanisms that I mentioned, calcitonin will reduce blood calcium levels. Then on this diagram, just for the hell of it, let's assume, oh my God, we overshot. Now the blood calcium levels are too low. Now what do we do? Well, parathyroid is like, all right, I'll help you out. Parathyroid hormone gets released, and through those mechanisms that I mentioned on the previous slide, that will work to then raise your blood calcium levels back up. Okay? Why is it so important that you have just the right blood calcium levels? Anyone know? I mean, I thought, isn't calcium just to make your bones hard? Isn't that all it does in the body? Yeah.
Is it also for like muscles?
Thank you. Yes. It's also for muscles. What else? Well, neurons. Okay. Do you remember when a neuron wants to release neurotransmitter? Do you remember at the very end of the axon, calcium actually has to rush in through voltage-gated calcium channels in order to release the neurotransmitter? Okay, that's another one. Enzymes. There are many enzymes that have to have calcium attached in order to turn on the enzyme. So calcium's not just to make your bones hard. There's a lot of really important jobs for calcium in your body, and so you've got to have the blood levels just right. Okay. All right, any questions about the thyroid or the parathyroid? Pretty good. All right, then the adrenal glands. What did the word renal mean again?
Kidney.
That means kidney, and then what did ad mean? Like to stick to, like an adhesive, right? So these are stuck to the kidneys. The other name, and you're welcome to use this other name, like on a lab quiz or a lab practical, is called the suprarenal glands, which is a pretty good name. What do you suppose supra means in this case? Yeah, it means like superior to, like or on top of the kidneys, right? So that is a nice description of where they are. So you can see them kind of sit on top like little party hats, top of the kidneys. Now, when you look at the adrenal glands, there are two areas to the adrenal gland. Like when you cut the adrenal gland, you'll see two areas. The area on the outside is called the adrenal cortex, and then the area in the middle is called the adrenal medulla. Now, we're going to talk about what each of these areas do here in a moment, but just so you know, you're going to encounter the word cortex and the word medulla a lot in the course, okay? It's very common when you have a solid organ to name the outer part of it the cortex part and the inner part the medulla part. So you'll see the terms cortex and medulla, like when we talk about the kidneys themselves, there's a cortex part of a kidney and a medulla part of a kidney. Or when we talk about the spleen, there's a cortex part and a medulla part. Or we talk about lymph nodes. Any solid organ, any organ that's not hollow on the inside, there's a very good chance that they use the term cortex to refer to the outside and medulla to refer to the middle, okay? Just wanted you to be aware of that. But specifically, what do these areas do in the adrenal gland? Well, the adrenal cortex makes steroid hormones, such as cortisol and aldosterone. How can you tell a steroid hormone just by looking at its name? Yeah, it ends in OL or it ends in ONE, right? The medulla, as I mentioned a little while ago, that's really just part of your sympathetic nervous system. That's going to release epinephrine and norepinephrine, okay? So they're a big player in sort of prolonging the sympathetic response. When you're freaking out, when you're having what's the nickname for a sympathetic response? Fight or flight, right? When you're having a fight or flight response, right? Something terrible is happening, right? This is the example I always use. Suppose you're being chased by a bear, right? And you're running away from the bear, and you're like freaking out, right? Totally freaking out. You're running away from the bear, and then your friend shoots the bear. The bear is definitely dead. Do you just suddenly get up and be like, that's a load off my mind, and just like walk away?
No.
No, you're like, oh my God, holy shit, what's just happened? Oh my God, oh my God. And you're like freaking out. Your heart's pumping. The bear's dead. That's happening because those hormones have been put into your blood, and as long as they're there, you're going to be freaking out. It takes a while, remember, to get hormones out of the blood. And so they work to kind of prolong the sympathetic response. The nervous system part, the neuron part of the sympathetic response, that's pretty easy to shut off. You can turn off neurons pretty quickly. But remember, hormone effects linger. And until you can get these two guys out of the blood, either via the kidneys or the liver, you're going to still be freaking out, okay? All right, adrenal cortex makes up most of the gland, 80 to 90% of the total weight. It's a tricky gland. I'll tell you, this is kind of a tricky gland for students to learn because there's a lot of little details. Also, under the microscope, there's a lot of stuff to identify on the adrenal gland. You know, not only do you have the cortex and the medulla part, they then like to subdivide the cortex into these 3 different zones. And for lecture exam purposes, you need to know what these zones do. For lab purposes, you need to be able to identify the different zones under the microscope slide. Anyway, so these are the zones of the cortex from outside to in. So the outermost zone, actually, let me just tell you, first you have something called a capsule. That's on the very outside. That doesn't do anything other than to just kind of hold it together, okay? But then you have this first zone called the zona glomerulosa. The zona glomerulosa makes what are called mineralocorticoid hormones. If you break this word down, the corticoid part is just telling you that the hormone came from the adrenal cortex. That's where the corticoid part comes from. The mineralo part tells you that the hormone is affecting certain mineral levels in the body, specifically sodium and potassium, okay? And by far the most common, well-known mineralocorticoid is this hormone called aldosterone, okay? So when you hear zona glomerulosa, think, you know, mineralocorticoids, but specifically think aldosterone. And I'll tell you more about aldosterone in a second. The middle layer of the cortex, and also the widest layer, is called the fasciculata. It makes glucocorticoids. Corticoid, again, means it's just coming from the adrenal cortex. The gluco part means glucose. And the reason they got that name is because glucocorticoid hormones make glucose available to your body. They free up and generate lots and lots of glucose to feed your body cells. And you may say, well, why would you want to do that? Well, if you have really active cells that need a lot of energy, you want to make glucose available to them so that they can, you know, eat that glucose essentially and use it as an energy source. And the most common glucocorticoid is your stress hormone, cortisol, or cortisone. It goes by both names. The reason why the stress hormone is a glucocorticoid is because during a stress situation, when your body's freaking out, fighting off some kind of a problem, some severe stressor, maybe it's an overwhelming infection, maybe it's overwhelming blood loss, your body cells are going to need a lot of energy. They're going to need to be fed to do their job. So cortisol is like, all right, I got your back. I'm going to make lots of glucose available to you so you can keep fighting the good fight. All right? That's really what it's doing. Which sounds nice, and it is nice. However, cortisol will do that by any means necessary. If it means breaking down your muscles, cortisol will do that. And so cortisol is high cortisol levels for a long period of time in your body, or if you're taking medications like prednisone that are basically drugs that mimic cortisol, these are really bad drugs to be on long term because they really change how your body looks. They break down muscle mass, they do all kinds of things just to make lots of glucose available. Okay. Last layer, zona reticularis, that's the innermost zone. That makes weak androgens. Anyone know what androgens are? Yeah, androgens are like testosterone. They're male sex hormones. Okay? Testosterone itself is a relatively strong androgen, but there are weaker forms such as this guy here, dehydroepiandrosterone, or DHEA. That's a weaker type of androgen. So that's what's going on there. So all of these hormones, they're all classified as steroid hormones. I'm going to say a little bit more about them now. So mineralocorticoids, they affect things like sodium and potassium levels. They also affect water levels. The reason for that has to do with osmosis. Where sodium goes, water tends to follow. So Aldosterone, which is the most famous mineralocorticoid, it causes your kidneys to retain sodium, and at the same time, the kidneys retain water. The way that aldosterone secretion is controlled is very complicated, and I have to explain this whole thing called the RAAS, which I'll do in a second. But that's a special system that controls the release of aldosterone. And you're going to learn it. You're going to hate me, but you're going to learn it. Darn it, and that's the end of the story. Glucocorticoids, cortisol, again, making lots of glucose available during stressful situations, okay? Your body needs extra energy during stress situations, and cortisol's like, all right, I'll help you out. Androgens are male sex hormones. Now, in men, it's interesting, this DHEA, it's like, doesn't have much of an effect because men already have testosterone coming from their testes. And testosterone is like a really strong androgen, okay? So you barely notice the effects of DHEA in a man because they've already got testosterone. In a woman, however, it's nice because after a woman reaches menopause, the ovaries are going to shut down and they're not going to make any more estrogen, okay? However, this DHEA stuff coming from the adrenal gland, structurally, chemically, is very similar to estrogen. They're all based on the cholesterol molecule, if you remember, and it's pretty easy to convert the DHEA into estrogen. So in a postmenopausal woman, they can still get a little bit of estrogen coming from the adrenal gland, even though, it's not going to be high levels like they got from their ovaries, but it still can be a source. All right, here it is for the first time, raising its ugly head. This thing's gonna come up at least once more, maybe twice more in the course. I'm gonna walk you through it. Yes, you're gonna have to memorize all those numbers down there and what they do. But I'm gonna walk you through it. First of all, I want you to remember the big picture though. This whole thing, this whole renin-angiotensin-aldosterone system, it's designed to prevent you from having a blood pressure that goes too low. That's the whole purpose of this. It's on the lookout for when your blood pressure starts to go low, and it's a negative feedback system. It's going to try to raise your blood pressure so that it doesn't stay low, okay? Everyone's always hating on high blood pressure, right? What's that problem called when you have high blood pressure? Hypertension. Everyone's always hating on hypertension. Oh, I got high blood pressure. Oh, I got hypertension. You know what's far worse than having a high blood pressure? Having a really low blood pressure, all right? When you have a really low blood pressure, you can't pump the blood around your body and organs start to shut down. So that's a really serious situation. Having a blood pressure that's too low is life-threatening, okay? And if you go to like any ICU, anywhere, you're going to see lots of low blood pressures if you go into the ICU, and you're going to see these people on all kinds of different medications that the doctors are giving them in an effort to try to keep their blood pressures up, okay? So you want to protect your body from bottoming out. You do not want a blood pressure that goes too low, and this whole system is designed to prevent that. So let me walk you through how this works. Just keep that in mind. That's the big goal. There's lots of little steps, but that's the big goal. So start here at number 1. Some problem happened that's causing your blood volume to go down, which then causes your blood pressure to go down. Maybe it's something just simple like dehydration. Today was the day that you decided, I'm not drinking water ever again. I hate water. I've always been mad about it. I'm not drinking. And so you got like dehydrated, okay? As you have less water in your system, that will cause your blood volume to go down, and then that'll lead to your blood pressure going down. Suppose it's something more serious. Maybe you got into a trauma situation and you actually lost a lot of blood. You're hemorrhaging. Your friend got pissed at you because of what you posted and they stabbed you in the femoral artery, right? And you're like spurting out blood here. You've lost a lot of your blood volume, okay? Whatever.
Where am I doing?
That's going to cause your blood volume to go down, which then causes your blood pressure to go down. Fortunately for you, of all places in the body, I know this is going to sound weird, in your kidneys are actually some specialized cells, we'll talk about them more later in the urinary system, called juxtaglomerular cells. They monitor your blood pressure. They're like, oh my God, the blood pressure's starting to go low. Let's fix this problem before it gets out of hand. And they start by producing this chemical called renin. And so renin is the first thing, or it's what the letter R represents up there. By the way, that system is named based on the order that those things come about. So you start by releasing renin. Renin will seek out a chemical that's already been put into your blood by your liver called angiotensinogen. Angiotensinogen is already there, the liver made it, but unless renin's around, angiotensinogen doesn't do anything. When renin's around, it converts the angiotensinogen into something called angiotensin 1. I know this sucks. If this is the first time you're hearing this, I know this sucks to memorize this stuff. Angiotensin 1 goes to, of all places, makes no sense, goes to your lungs, and in your lungs is an enzyme there called angiotensin converting enzyme, or it's abbreviated ACE. ACE converts the angiotensin 1 into angiotensin 2. What does the angiotensin 2 do? It goes to the adrenal gland, and it causes the adrenal gland to release aldosterone. How does aldosterone help? And again, if you follow along, we went from renin ultimately to angiotensin. Now we're finally getting aldosterone to be released. What does aldosterone do that's so great? Well, aldosterone will go to your kidneys, and it will tell your kidneys to hold on to sodium. And when your kidneys hold on to sodium, they'll also hold on to water. So, in other words, you don't pee as much. Instead, you pull the water back into your system. By holding on to the more water, you eventually bring the water and the sodium back into your blood, and that increases your blood volume, which in turn increases your blood pressure. Okay? So retaining water and the sodium will help to then raise your blood pressure. The other thing, though, that angiotensin 2 does that's kind of nice to help is it also, if you follow this arrow, it's a direct vasoconstrictor. What does vasoconstriction mean? Yeah, it tightens up your blood vessels. That too helps to raise your blood pressure. So both of those effects, holding on to more sodium in water and tightening up your blood vessels, together both of those help to raise your blood pressure, which was what the problem was in the first place. It's just a convoluted series of steps to get there, right? One thing I want to tell you, two things I want to tell you, but one thing I want to tell you first is, has anyone heard of ACE before? Where'd you hear of ACE?
Like in a class when I'm talking about medications.
Yeah, and what medications have the word ACE in it?
ACE inhibitors.
ACE inhibitors, bless you. And what are ACE inhibitors used to treat? High blood pressure, all right? There's a class of antihypertensive drugs called ACE inhibitors, and they block that enzyme so that you never get this angiotensin 2, so that you don't have those effects happening that would tend to raise your blood pressure. So it's a great ACE inhibitors are great medications when you do have someone that has hypertension, because it's basically shutting down the formation of angiotensin 2, which is a strong chemical to raise your blood pressure. Okay? That was the one thing I want to say. The other thing I want to say has to do with how you can avoid going through this whole thing and still get aldosterone to be released. And that has to do with step 16 over here. So you can still get aldosterone to be released if you have a particular problem in your body called hyperkalemia. Does anyone know what is hyperkalemia? It's high potassium levels in your blood. Okay? If you have that problem, which is essentially what they're saying here, they just said it a different way, increased potassium and extracellular fluid. If you have that problem, that will directly cause the adrenal gland to release aldosterone without having to go through all these other crazy steps. Okay? Why is that beneficial? Well, because, and I didn't tell you this yet, there's something else that aldosterone does. Besides causing sodium and water to be reabsorbed, at the same time, it actually causes your kidneys to get rid of potassium. It causes you to pee out potassium. So aldosterone is great when you have this problem of hyperkalemia because it will help to get the potassium out of your body. Okay? Now, why is it such a straightforward one-shot step? Like, why did we have to go through all these steps before with the low blood pressure problem? But here, with the high potassium problem, they just made it a one-shot deal. Why is it so much shorter and easier if you have high potassium to get aldosterone to be released? Does anyone know? I mean, I'm sort of speculating here, but it makes sense. Does anyone know?
Is it based on the gates that are available, maybe? Like potassium just leads.
I'm looking for more of a. That's a very that may be correct. That's a very detailed answer. I'm looking more for like a. I don't know how to put this. Severity of problem, I guess, is what I'm looking for. Let me just. I'm not making myself. I'm making totally unclear. If you had to, hyperkalemia. If you had to rate hyperkalemia on a scale of 1 to 10 in terms of severity, with 1 being not that big a deal, to 10 being a really big deal, where would you rate hyperkalemia?
5.
What'd you say? You said 5. What did you say? Are you raising your hand? Sorry, only Corey raises his hand. I'm sorry. No, it's like an 11. Hyperkalemia is like an 11. Okay. Why is hyperkalemia so bad? Yeah. Your neurons need it, specifically the neurons and the electrical signaling involved with what organ? Heart. Hyperkalemia stops your heart from beating, like real quick. Okay? And here's a memory trick for how you know that it starts your heart from beating. Okay, you're aware of like the death penalty, right? All right. Anyone ever been through the death penalty? No, I'm just kidding. But you better go to some place like, I don't know, Texas or wherever they do a lot of death penalty stuff. And when they kill the prisoners, it's 3. They've updated their methods in recent years, but it used to be 3 different chemicals. All right. The first chemical like basically sort of relaxed you. The second chemical like I don't know, put you to sleep or something. But it's the third chemical that actually kills you. Do you know what that third chemical is? It's just potassium. It's not some crazy poison. It's not cyanide. It's just a mega dose of potassium, and it stops their heart cold. Okay? So that's a good memory check for remembering that this is a really bad problem. So my point is that your body's kind of smart this way. Your body's like, oh crap, this is a serious problem. Let's not go through all these other dumb steps like we had to before. Let's have this problem directly cause aldosterone release so we can pee out that extra potassium.
No, I think that's actually what they use though, because
well, of course it is. You think I'm lying to you?
no.
He went through it.
You said like the 3 injections, but I think it goes through only things like usually what they say like on death row is that like when you get that injection, the person dies like right away.
Yeah. Well, see, I know in recent years there have been some like. So like, first of all, I'm not up on my death penalty readings recently. I've had my subscription lapsed, but they have made changes where I think it's a 1 drug thing now in certain states.
Yeah.
But I don't know what that 1 drug is. But like the purists like me, we'll always love the potassium. But there's like newer drugs that the new school people like to do. Yes.
What would cause high potassium levels in like a person without obviously
Well,
injecting?
if you have like kidney problems, for example, that could lead to hyperkalemia. Like you're just not able to filter your blood properly and get the potassium out. That could be a
If
cause of
someone
it.
loves bananas, would they get high potassium? No, all seriousness though. Like let's say someone just loves bananas.
So, I've read, it's a very good question. I've read up on that. I've heard something to the effect like you would have to eat like, I forget, like it's like 3 bunches within like a 10-minute period and then like not vomit and like you'd really have to knock yourself out. It's almost impossible to do.
If you
Yeah.
had 1 banana every day, like part of breakfast, you wouldn't.
No, I don't want you to be fearful of eating bananas now. Like as you walk, like take like a wide berth in the house as you walk by those scary bananas, right? I don't want you to do that. Okay. Yeah, no, you'd really have to overdo it. All right. All right, glucocorticoids, these are your stress hormones. We're mainly talking about cortisol here. The big thing is they're making glucose available, and they're doing it through different methods. And they don't cortisol doesn't care what it needs to do to make glucose available. It will break down your proteins, and then those amino acids from the proteins can be put through a process called gluconeogenesis, where they get converted into glucose. So, you know, it will seek out protein pretty much anywhere, and unfortunately, you have a lot of proteins like myosin and actin and whatnot in your muscles. So high levels of cortisol in your body for a time will start to change your physical appearance and cause you to break down muscle mass and things like that, and it's kind of bad that way. It also promotes, I mean, obviously this isn't too bad, but it promotes lipolysis, which is fat breakdown. There's also ways that the fats can then be converted into glucose as well. Cortisol, again, is providing resistance to stress by basically making lots of glucose available to your body cells so that they can fight off the stressful situation, okay? Another benefit that they do during stress situations is they make your body more sensitive to hormones that vasoconstrict, okay? Such as epinephrine and norepinephrine, which come from the adrenal medulla, right? When you are in a stress situation, overwhelming infection, overwhelming blood loss, whatever the problem is, it's fairly common for your blood pressure to run low. So cortisol is like helping out in this way. It's saying, all right, listen, your blood pressure is going to probably run low. I will make it so that some of these other hormones have a stronger effect on vasoconstriction, and that'll help to raise your blood pressure. Okay. As you probably know, if you've gone to CVS or anything anytime soon, they do have topical forms of cortisol or cortisone, and they have anti-inflammatory effects. So you can like put it on a rash or something like that, and it'll have anti-inflammatory effects. In your body, systemically, not topically, but like in your body systemically, cortisol can actually block your immune responses. And one situation when they use cortisol, or I should say they use medications like prednisone, which are similar to cortisol, is when they want to relax your immune response, when they want to suppress your immune response. For example, you get a patient that has like a kidney transplant or a heart transplant or some other transplant. They're getting foreign tissue from someone else. Our immune system's natural response would be to attack that as foreign and destroy it. You obviously don't want to reject that transplant that you're getting, so prednisone is one class of immunosuppressive drugs that they might put a transplant recipient on so that they don't reject the organ. Okay. Now, too much cortisol or too much prednisone or too much of any kind of drug that's like cortisol can cause Cushing's syndrome. So, you know, maybe you have some disease of your adrenal gland, like maybe you have a tumor there and you're simply releasing, you know, more cortisol because of that tumor. Maybe you have a pituitary gland tumor, which is causing you to release ACTH, which is then going down and causing you to release cortisol. Or maybe it's simply because you've been on a drug like prednisone long term. There can be a number of causes of Cushing's syndrome, but Cushing's syndrome sucks, all right? You don't want to get Cushing's syndrome. Unfortunately, there are people that have to take oral steroids, prednisone and whatnot, and if you've ever had any friends or anybody that's been on oral steroids for a while, it really changes their physical appearance, okay? These are a really bad class of drugs to be on long term. Sometimes it's the only option, but what happens is it starts to break down fat, starts to break down muscle, it breaks down fat, it redistributes it, and you get kind of this, they describe it as spindly arms and legs, moon face. You don't have to tell me you don't want a buffalo hump at the neck, right? There's a lot, it does things that, I don't know who the person was that named that. I mean, that probably been kind of hurtful for the first patient, but whatever. You don't want to get those things. Not surprisingly, you get hyperglycemia because, again, the main effect of cortisol is to free up and make a lot of glucose available. Poor wound healing can happen when you're like impairing your immune response and other things. So it's just Cushing's syndrome is a bad thing to get. It can really, devastate you like emotionally and other things. Another adrenal gland related disease in which you don't have enough cortisol and in which you don't have enough aldosterone is Addison's disease. So this is low levels of cortisol and low levels of aldosterone. What causes Addison's disease? Well, it might be due to an autoimmune condition where your immune cells simply get confused and they start attacking your adrenal gland. And as they attack your adrenal gland, they destroy the cells in the zona glomerulosa, they destroy the cells in the zona fasciculata, so you're not making as much aldosterone, you're not making as much cortisol. What's the impact of that? Like, what are the signs or the symptoms you see with Addison's disease? You can kind of predict, if you know what those hormones do, just take a step back and ask yourself, what would happen if they're not around? And then this stuff starts to make sense. So you see, what's hypoglycemia? That's low blood glucose levels. Remember, cortisol tends to raise blood glucose levels, so if it's not around, you're probably going to have hypoglycemia, right? Sodium loss. Remember, aldosterone is in charge of causing you to resorb sodium in your kidneys and not pee it out. So if it's not around, you're going to lose a lot of that sodium in your urine. Low blood pressure. Again, aldosterone, when it's promoting sodium reabsorption, it also promotes water reabsorption. That increases your blood volume, which increases your blood pressure. If you're not doing that, then your blood pressure is going to probably run low. As you pee out more water, you're going to become dehydrated. As you start to change electrolyte levels, such as potassium and sodium, that can lead to problems with like muscle weakness. Okay? I mean, if I had to pick between the two, I guess I'd rather have Addison's disease, but it's still not like an awesome disease to have. The most, I don't know if he's the most famous, but this is a kind of anyone know who that is? JFK. So President Kennedy, he had Addison's disease. Yeah. Well, like I said, sometimes you may want, so the corticosteroid drugs are good at suppressing your immune system. So if you have a disorder, like you're trying to receive a transplant from someone, you might be put on it for that reason. If you have an autoimmune disease where your body's attacking itself, you might be put on it just to kind of relax your immune system a little bit. Yeah.
So if you were on those drugs, would that make you more likely to get sick in other ways?
Yeah. I mean, it makes you more likely to get Cushing's syndrome, right? It's all, I mean, listen, no drug is ever like perfect, you know? There's always like side effects, and these just happen to, these guys have a really bad side effect profile. Yeah. All right, where am I going? Okay, adrenal medulla, I think is a little bit easier than the cortex. The adrenal medulla, think of it kind of like a sympathetic ganglion from AMP1, okay? During I don't want to like rehash this whole thing, but in chapter 15, we did the autonomic nervous system, and you may remember the horror about preganglionic neurons and postganglionic neurons. This is kind of like, the adrenal medulla is kind of like a ganglion. Inside of it are postganglionic neurons that release a neurotransmitter. But instead of releasing that neurotransmitter and having it stimulate some effector, those drugs are being, those chemicals, I should say, are being released into your blood. Okay? And those two chemicals are epinephrine and norepinephrine. And as I mentioned before, their purpose is to prolong the sympathetic response, right? Just because that bear is shot dead doesn't mean you suddenly stop freaking out, right? Pancreas. I think there's probably a law that says every textbook, the first sentence about the pancreas has to be this one up here. The pancreas is both an endocrine and an exocrine gland. Fine. Which is it more of? Like by size, is it more endocrine or is it more exocrine? Does anyone know?
Looks like he has a dog.
I heard it's sort of half-hearted exocrine. That's right. It's more exocrine. 98% of the pancreas are these little acini, and they produce digestive enzymes which get secreted into the ducts of the pancreas, and then they get dumped into your small intestine and they help you digest your foods. So 98% of the pancreas is devoted to that. It's exocrine. which means only 2% is endocrine. And we're going to focus on that 2% right now, but later on when we do the digestive system, we'll go back and we'll talk about the other 98%. The 2% that does the endocrine is referred to as the pancreatic islets, or the islets of Langerhans. And you'll have to identify those under the microscope. So when you look at the pancreas under the microscope, you're mostly going to see the acini. They're going to be everywhere. They're all over the place. But every now and then, you may see a smaller cluster of cells, usually a little bit lighter staining, and that's going to be the pancreatic islets. I would tell you, some of our pancreas slides in here are not that good, and I have a really hard time finding any islets. But there are a few, there is at least like 2 good slides roaming around, so see if you can find those that really do show the islets well. So, what kind of hormones are we talking about? What's probably the most famous hormone that comes from the pancreas? Insulin, right? That's the most famous one. But there are 3 other ones that you should know about. So first of all, they have different cell types that are in these islets, right? And they're named, the cells are named based on Greek letters. Well, at least they started to be. And then I don't know if the person that was naming them just didn't know the Greek alphabet that well, and they kind of ran out of names. So it's alpha, beta, delta, and then PP. I don't know. Let me go through what each of these cells do. First of all, the alpha cells, you would think, at least I would think, that the pancreas is kind of known for making insulin, so you would think the alpha cells are the guys that make insulin. That's wrong. The alpha cells make glucagon. Glucagon increases blood glucose levels by two means. Something called glycogenolysis and then something called gluconeogenesis. Now, these are what I call some of the terrible G words. We're going to learn a hell of a lot more about those terrible G words in the last chapter we cover in the book, which is chapter 25. But let me just describe briefly what they do. Glycogenolysis takes glycogen, which has been stored in your liver or in your muscles, and it breaks it down into the individual glucoses, and then it puts those glucoses in the blood. So that raises blood glucose levels. Gluconeogenesis is taking something that's not a carbohydrate, such as an amino acid or something, and then converting it into glucose. And then that's another way of raising blood glucose levels. Okay? So the whole purpose of glucagon is to increase your blood glucose levels. Any guess, during the day, when will your body start releasing glucagon? Let me make this simple. I'll give you 2 choices. Will it release glucagon after you've just eaten a meal, or does it release glucagon 3 or 4 hours later? Later, all right? After you've just eaten a meal, your blood glucose levels are going to be really high. You don't need them to go up any higher, right? But as you get further and further away from your mealtime, your blood glucose levels will naturally start to go down. And that's the point when your body will be like, oh, we got to keep those blood glucose levels up, mostly to keep the brain happy. And that's when it'll release glucagon. So the glucagon, I like to think of it as the 3 or 4 hour after I ate hormone, right? That's when glucagon starts getting released. The beta cells, which are actually the most common, 70%, they're the guys that are, I guess, arguably the most famous because they're the ones that make insulin. Insulin reduces blood glucose levels. And it does that by actually putting glucose channels into your body cells so that they can pull the glucose out of your blood and bring it into themselves so that they can then use the glucose as an energy source to meet their needs. The other way that it reduces blood glucose is by causing the liver to take up any extra glucose and convert it into glycogen for storage. Okay? So when you eat a meal, your blood glucose levels are going to go up pretty high, and that's the time when you release insulin. Okay? So insulin's like the I just ate hormone. Insulin gets released, and its job is to reduce the blood glucose levels down into their normal range again. It does it by allowing some of the blood glucose to go into the body cells to make them happy to feed them, and then anything left over gets picked up by the liver and converted and stored in the form of glycogen. That process of storing it as glycogen, that's referred to as glycogenesis. That's another one of the terrible G words, all right? The other thing to know about insulin is it's also a promoter of, it's a big anabolic hormone. Number one, it causes you to make glycogen. It also promotes fat synthesis and actually protein synthesis. So it's a big anabolic hormone. This is the reason why you need to be careful when you eat like a sugary food, such as candy, such as like Sour Patch Gummies, just saying, happen to like them. You read the label on things like that, and it'll say zero fat. They may even advertise it on the front, like this is a zero fat food, right? You get all excited, oh, it's zero fat, I'm gonna eat like 1,000 of them, right? It's zero fat in the box, right? It doesn't mean that once it gets into your body, all of that glucose, guess what? After it's whatever's converted into glycogen, anything that's left over that's floating around in your blood, it's probably going to get converted into fat and stored in your fat tissue, right? So, you know, don't go patting yourself on the back thinking you're like some health nut because you just like ate 2 million, you know, Sour Patch Kids. Like, it's going to get stored up as fat, okay? This is showing you the kind of interplay between glucagon and insulin secretion based on blood glucose levels. So over on the left, let's suppose it's been a couple of hours since you last ate. So your blood glucose levels are naturally going to start to fall. So you have hypoglycemia. That will stimulate the alpha cells to produce glucagon. And then through those effects that I mentioned on the previous slide, I'm not going to read them all again, but through those effects, that would then work to increase blood glucose levels and hopefully bring it back up into the normal range. Okay? Again, the whole reason why you have this range, you know, this area where your blood glucose levels should be at, is mostly to keep the brain happy. The brain needs a nice steady supply of glucose. It doesn't store up any glucose in its own cells. It's very picky. It doesn't like other energy sources, so you got to keep it kind of high to at least make the brain happy. If you have just eaten a meal, after you just eaten a meal, chances are you're going to be a little bit hyperglycemic. Blood glucose levels are going to be a little too high, so now you want to bring them down. That's where insulin helps you out through those mechanisms that I mentioned. You'll then reduce your blood glucose levels, hopefully back within the normal range. Okay. Any questions about either of those two guys? So those are like the two famous hormones, especially insulin. There are two other hormones that you should know. Delta cells make something called somatostatin. Somatostatin, I like to think of as kind of like the reset switch for the pancreas. Somatostatin turns off both insulin and it kind of calms down the pancreas. It turns off both insulin and glucagon release from their cells. Okay, shuts them down. The interesting thing about somatostatin that someone figured out along the way is that you can also find somatostatin in the hypothalamus. The hypothalamus releases somatostatin, and in that context, somatostatin actually goes from the hypothalamus down to the anterior pituitary, and it stops the anterior pituitary from releasing human growth hormone. So instead of just carrying the same name, somatostatin, somebody decided, oh, we need a new special name for it up here. So they call it, in the hypothalamus, they refer to it as human growth hormone inhibiting hormone. Same exact chemical, just a different name based on where it's at. Okay. PP cells stands for pancreatic polypeptide cells. These guys actually can inhibit somatostatin secretion. So if you think about how this all fits in, pancreatic polypeptide can help to turn on insulin and glucagon secretion, right? If this guy is blocking insulin and glucagon and you're stopping this guy, then you're indirectly turning on insulin and glucagon secretion. Pancreatic polypeptide also causes the gallbladder to contract. Anyone know where's the gallbladder located? So you put, okay, good. Yeah, you fixed it up. First you were over here, and then the other. Anyway, yeah, the gallbladder's over here. It's just underneath the liver. What's inside the gallbladder? Bile. What does bile do? It sort of, we'll cover this more later, but it basically helps you digest fatty foods. Like if you have fatty foods in your meal, which most of us have a little bit, you need bile to kind of help digest that. So the gallbladder squeezes to do that, and then pancreatic polypeptide facilitates that. Also, it causes the pancreas to secrete some of its digestive enzymes. We'll get into all these details when we do the digestive system chapter. Ovaries. Ovaries are part of both the reproductive and the endocrine system. Probably the most famous hormone from the ovaries is estrogen. Just remember, estrogen is not one hormone. It's the name for a family of hormones with individual members such as estradiol or estrone. So estrogens are steroid hormones. Estrogens, progesterone is another hormone that comes from the ovaries. They're going to interact with some of the hormones that come from your anterior pituitary, like FSH and LH, and together they'll regulate the menstrual cycle, they'll help keep a pregnancy going, etc. They promote female secondary sex characteristics. We'll get into all these kind of details in chapter 28, which again is at least how it was explained to me. That's the reason why we do chapter 28 after this one, because hormones are kind of fresh in your mind, and so we go on to the reproductive chapter. But we'll go into excruciating detail in that chapter of how like all those hormones work. There's another hormone called relaxin that's released towards the end of pregnancy. Okay, it's supposed to make some changes to make it easier for the baby to be delivered. It relaxes. I don't know who named this hormone. It's kind of a good name. It relaxes the pubic symphysis. What was the pubic symphysis? Yeah, it's kind of the cartilage in between the pelvic bones, kind of at the front of your pelvis. It's basically a joint, and when this relaxin's there, it loosens up that cartilage, and that causes the whole kind of circumference to widen to make it easier for the baby to pass through the pelvis. The other thing it does is it helps to dilate the cervix. That makes it easier for the baby to come out. It also relaxes the coccyx. What's the coccyx? Yeah, the tailbone, right? So that can kind of bend backwards when the baby's trying to come out. Last thing you want is like a scraped forehead from a coccyx scrape. That's so embarrassing, right? You don't want that. Oh my God. Like you look around, you'll see people that have scrapes. You're like, yeah, I know what happened to you, right? Inhibin it does what it says. It inhibits something. It's going to inhibit FSH release from the anterior pituitary. It's a way for the ovaries to kind of talk back to the anterior pituitary. Okay, the ovaries have follicles inside of them. Follicle stimulating hormone is stimulating those follicles. When the ovary's like, I've had enough, stop stimulating my follicles, it releases inhibin, and that stops it from happening. Testes, same type of deal as the ovaries, part of both the reproductive and the endocrine. The main hormone is testosterone. Testosterone is a strong androgen. Testosterone is needed for sperm production. Anyone know the fancy name for sperm production? There you go, spermatogenesis. We'll cover that a lot in the next chapter. It also promotes like male secondary sex characteristics, like male hair growth pattern, deeper voice, things like that. The testes also make inhibin that can go up and again interact with the anterior pituitary. Pineal gland, we covered this in AP1, maybe you'll remember it. It's part of an area of the brain called the epithalamus, and the pineal releases melatonin. When in a 24-hour period are melatonin levels high? Yeah, when it starts to get dark. I forget exactly what time. I think it's something like 2 a.m. or 3 a.m. I forget exactly when they peak, but yeah, they start to go up as it gets dark outside. When it's light out, the light comes in through your eyes and it actually inhibits the pineal gland, from releasing melatonin. As it becomes darker, that inhibition is removed, pineal gland produces melatonin, and then the melatonin is supposed to kind of relax you and make you sleepy. Thymus, personally, I think it's kind of dumb that we talk about the thymus now. The thymus is Most people consider it a big player in the lymphatic system. However, it does technically make a hormone called thymosin, so okay, fine, we could consider it here. You'll learn a heck of a lot about the thymus in the lymphatic system. It's basically a place where certain types of white blood cells go to learn how to fight, okay? There's a type of white blood cell called a T cell. The T actually stands for thymus. T cells, like all of your blood cells, are made in the bone marrow. But unlike the other white blood cells who get their training in the bone marrow, the T cells are sent to the thymus to get their training. Okay? I had a professor in medical school that referred to it as T cell university, right? That's where they all go to get their training. Other endocrine stuff. Actually, hold on. Where am I at here? Okay, I'm gonna do this slide, and then I'm gonna let you take your break, and then I'll finish up the stuff as you come back. So, other endocrine tissues that maybe you don't think of as being like an endocrine gland, but they have some kind of an endocrine function. I mentioned a lot of these on Tuesday, but I'll just say it again. The heart. You think of the heart as being part of what system? Cardiovascular, right? It pumps the blood, etc. Turns out the heart does produce a hormone called atrionatriuretic peptide that helps to reduce your blood pressure. When your blood pressure is too high, the walls of the heart get stretched, especially the walls of these chambers that are called the atria. They get stretched. And when that happens, the heart's like, oh my God, the blood pressure must be high. Let me help out by releasing atrionatriuretic peptide. Atrionatriuretic peptide is kind of like the exact opposite of aldosterone. Aldosterone causes you to retain sodium in water, whereas atrionatriuretic peptide causes your kidneys to get rid of sodium in water. When you get rid of sodium in water, that reduces your blood volume, which in turn reduces your blood pressure. Okay. Adipose mentioned leptin. Leptin is supposed to make you feel full, right? So, like I said, the more adipose tissue you accumulate, in theory, the less hungry you're supposed to be. What was the antagonistic hormone to leptin? Ghrelin. Yeah, ghrelin. And where did ghrelin come from? Stomach. Yeah, so when you haven't eaten in a while, the stomach's like, oh man, I'm bored, and I haven't been stretched in a while. You know, my pH is kind of low right now. I need something to fill me up. It'll release ghrelin, which will go up, and you'll be like, I feel kind of hungry. I got to eat something. So those two are kind of working against each other. Prostaglandins and leukotrienes, these are eicosanoid hormones. They're under the category of lipid-soluble hormones. Remember, they come from a 20-carbon fatty acid called arachidonic acid. These hormones are local hormones, okay? You don't put these guys into the blood, they don't circulate, but they do act locally. When you hear either the name prostaglandin or leukotriene, I think the first word that should come to mind is inflammation. They both promote inflammation, which is all about, you know, like attracting white blood cells to an area where there's a problem so that the white blood cells can then fight off the infection or whatever the particular problem is. So prostaglandins promote inflammation, which includes things like pain and fever and other things. There's not just one prostaglandin, it's actually a group of prostaglandins. And there are some that are involved in inflammation. There's others that do things like regulate smooth muscle contraction. There are some that influence gastric acid secretion, some that affect the size of your airways. A number of our popular pain-relieving drugs work by blocking the formation of prostaglandins. Okay? Aspirin works by blocking an enzyme that makes prostaglandins. The NSAIDs. What does NSAID stand for? Yeah, non-steroidal anti-inflammatory drugs. Those are things like Motrin or naproxen, those kind of medications. They work by blocking the enzyme that leads to prostaglandin formation. It's actually the enzyme is called cyclooxygenase, okay? And by blocking that enzyme, you stop prostaglandin formation, okay? Unfortunately, one thing that happens when you block that enzyme completely is you knock out like all prostaglandins. What's one of the side effects people complain about when they have to be like on ibuprofen or Motrin for a while? They get an upset what? Stomach. That's because some of the prostaglandins actually help reduce stomach acid secretion. Some prostaglandins lower stomach acid secretion. So if you block the formation of all prostaglandins, yes, you're going to prevent inflammation and the pain and the fever and all that other stuff that happens, but you're also going to indirectly increase stomach acid secretion, and you can get an upset stomach. So I don't know, about 30 years ago or something, the abbreviation for this enzyme is COX, C-O-X. About 20 or probably 25, 30 years ago, somebody came up with a new class of medications called COX-2 inhibitors that are designed to only block one version of this, so that you basically knock out the prostaglandins that promote inflammation, but you don't knock out the ones that prevent stomach acid secretion, etc. So like, you may have heard the drug Celebrex. There's an older one called Vioxx. Those were COX-2 inhibitors, and they were supposed to be good for people that wanted the anti-inflammatory effects, but without the side effects of like stomach upset and things like that. Okay. All right, go ahead, take your break, come back. I have a little bit more to get through, and then we will do the lab stuff. It's a combination of different stages that you go through when you're experiencing some stress. The point of the stress response is it really doesn't matter what the specific cause of the stress was. It could be anything that's just overwhelming for you, like a serious infection or blood loss or even psychological stress. But regardless of what the cause is, they found that your body goes through like these 3 stages. So first is essentially a sympathetic response. It's your fight or flight response. It happens, quickly because it's easy to turn on the sympathetic nervous system, and it's quick. In the second stage, they call that the resistance reaction. That's really when the hormones like cortisol and the other hormones that are involved in stress, that's when they start getting released and start playing their part. And then hopefully, if you're lucky, you don't go any farther than that. You go through stage 1, you go through stage 2, and hopefully your body like wins the battle against whatever stressor it is, and you recover and you're fine. But if you're not successful, if it's just too serious of a stress, your body will eventually become tired, and it starts to get exhausted. And you go into the third step, and that's when, your individual organs start failing, and then organ systems fail, and then multi-system organ failure, etc. And then, you're circling the drain, it's all over. All right. So, fight or flight, sympathetic, fine, we know about this. What were some of the body changes you see with the sympathetic response? So, yeah, increased heart rate, dilation of your pupils, increased diameter of your airways, right? What happens to things like salivation and movement of your intestines and things? Yeah, they decrease, right? You shut those things down. You change your blood flow patterns during a sympathetic response so that you're sending more blood flow to the essential organs to help you fight off or run away from the problem. So you send a lot of blood flow to like your skeletal muscles. Obviously, you got to send some to your lungs so that you can oxygenate your blood. You want to try to think as clearly as possible, so you're sending increased blood flow to like your brain. As I said earlier, a lot of times when you have a stress situation going on, your blood pressure is going to fall. Like there's a lot of bacteria, for example, that have toxins that can cause hypotension. They can reduce your blood pressure. Or if, obviously if it's like you had a hemorrhage situation where you lost blood, that's going to bring your blood pressure down. So you see low blood pressure a lot with stress, so it kind of makes sense that you would turn on the RAS just as a protective measure to try to keep your blood pressure up. The resistance reaction, think hormones. That's when the cortisol is getting released, along with some other hormones that can help out too, like thyroid hormones can help out by increasing the rate that your body cells, work, that they use the glucose and things like that. And then lastly, exhaustion. If it's just been going on too long, your body will eventually get tired out. And, by that point, you've had high cholesterol levels for a while now. Cholesterol, as I said, with that Cushing syndrome, it's a bad actor, and it's going to cause wasting of your muscle over time, just trying to keep your blood glucose levels up. It's eating away at your muscles. High cortisol levels eventually suppress the immune system, which makes it harder for your white blood cells to do their job. You may have heard of the term stress ulcers. High cortisol levels can actually lead to physical ulcers in your stomach, in your small intestine, etc. The beta cells may get worn out from trying to churn out lots of insulin so that the glucose can get into your body cells so they can feed themselves, but eventually they can get tired out and not produce as much insulin. So all of these things, they get tired out, they wear down, one organ fails, then another, and it's all over. This diagram is showing you the first two stages. So I'm not going to go through it, but it's basically just a good summary of some of the stuff. So on the left here, you have the fight or flight, this is the first stage with the sympathetic system kicking in. And then here in light tan, you've got the resistance reaction where you're getting the hormones involved. The main one is cortisol, but you have assistance from some other hormones like your thyroid hormones, which can, increase the metabolic rate in your body cells and help them work faster. Insulin-like growth factors, those come from the liver. They're due to growth hormone going to the liver and then stimulating the liver to release those guys. Similar to some of the effects of cortisol, they can promote lipolysis. They can do glycogenolysis, which makes more glucose available by breaking down the glycogen that's in the liver. So all of them are kind of working in the same direction to help you fight off the problem. Development of the endocrine system changes with aging. So in chapter 29, which we will cover next week, chapter 29 is the last chapter in the book. But like I said, we skip around a little bit. So we'll do 28 first, that's the reproductive system. Then we do 29. 29 is development and inheritance. And in that chapter, you'll learn about the early changes that happen when you're an embryo and you're a fetus. One of the things you'll learn about in that chapter is that there are three primary, what are called primary germ layers. These are like tissues, basically, that all of the other body tissues are going to come from. That's essentially what they are. And there's the ectoderm, the mesoderm, the endoderm. You've probably heard of these like in a general bio class or something before. Your textbook spends a lot of time at the end of each chapter telling you where each organ system came from. Like, the nervous system, it comes mostly from the ectoderm, for example. So your textbook does that, and in this particular chapter for the endocrine system, you should know that because endocrine glands can be found all over the body, they actually come from all three layers. They come from the ectoderm, they come from the mesoderm, they come from the endoderm. Your endocrine system turns on, or at least some of it turns on, obviously, before you're even born. I told you how important it was to have your thyroid working before you're born so that your nervous system can develop normally. Most other hormones in your body turn on and start working before you're even born. The exception is some of those hormones that are related to reproduction, and they're delayed and they don't really kick in until puberty. And we'll discuss all of this in the next chapter. Secretion of male hormones, for better or for worse. Male hormones, testosterone, men start churning that out at puberty, and they pretty much keep churning out the testosterone for the rest of their lives, all right? There might be a slight decline when you get older. If you watch the same crappy television networks that I watch, there's like, buy Total T, it'll make you feel like a man again. Like, your testosterone's low here, but there's like Doug Flutie, this washed up quarterback, and he's like throwing the ball, I'm taking Total T, so should you. And like all this stuff, it's like such nonsense. But
man, take this TRT.
You're taking TRT?
No.
Oh, okay. I don't even know what it is.
That's what older men take, like TRT, or like how these bodybuilders do, but like now you like this regular men that take TRT just to like update
your testosterone levels. Yeah. So men, it definitely is true that men do get a slight decline in testosterone levels. That's natural, but it's not nearly as pronounced as what happens in females, right? At menopause, the ovaries are basically going to shut down, and then all of a sudden there's this huge drop off in estrogen levels. Okay. And we'll talk more about both of these things in the next chapter. One thing I want to mention, I don't think this is in your PowerPoint, but I just wanted to close on this note. Pheromones. Has everybody heard of pheromones before?
Natural odor.
Yeah, like your natural odor that's like supposed to like kind of be sweated off into the environment, and then other people snort it up, and hopefully they'll feel like attracted. Go ahead.
It's actually a real thing. Like I'm not like it's actually a real thing. So like when women are on their period,
Yeah.
apparently like there's like a certain scent comes off,
Yep.
and like biologically like men can smell it,
Uh-huh.
and that makes men want to like like I guess what,
Take them out to dinner. What do you?
yeah, like they must be more attracted to the woman because it's a sign of like the woman's like fertile.
Yeah.
And like so biologically speaking, like
It make- no, I-
in their years, like that's when men knew that like a woman was like fertile to reproduce.
Yeah, no, I think I'm not disagreeing. I think I've heard something similar to that. Yep. How exactly and to what extent these pheromones actually do their job, that's kind of up for debate. You know, if you do pheromone search on the internet right now, you're gonna see all these hits for like different pheromone mixes that'll make you irresistible to people of the opposite sex and all this stuff. Exactly how strong an effect they have, it's up for debate. One theory about how they work, though, is that they may influence oxytocin levels in a person. So when you inhale these pheromones that another person's giving off, it may have an impact on your own oxytocin levels. Oxytocin is, in addition to being the thing that causes the baby to be squeezed out by the uterus, in addition to the milk ejection, it does thought to play a role in social bonding. And so they have noticed like they think that may be the way that pheromones work by altering oxytocin levels. But how strong an effect it is up for debate. I just want to close with one thing in here, see if anybody had been to pheromone parties. Anyone gone to a pheromone party? Hold on, well it could be, or I'm not judging, it could be anything you want it to be, but no one's been to a pheromone party in here. Have you really, Ryan?
He had his cowboy hat on that day.
You look like you might benefit from it. So you're gonna want to go. Trust me, you're gonna want to go to this after I explain it. So, like all crazy ideas, this began in California, and the thing with pheromone parties is here's what you do. The night before the party, you're instructed to go to bed in a clean white T-shirt. Put that on. You sleep in it. Then the day of the party, you wake up. You take that T-shirt off. You put it in a Ziploc bag. You get all gussied up, nice, looking nice, and then you go to the pheromone party and you hand your Ziploc bag with your T-shirt in to the host, and they secretly write down some little code on the outside of the bag that identifies it to you. And then they swap all the bags between the men and the women, and then there's this big ceremony where everybody gets a chance to open the bag and sniff it. And then they decide who they might want to date simply based on the scent of the bag. And then at the very end, they reveal who the bags belong to, right? So here, I don't know if she's like satisfied or not satisfied. What's that?
Now you wonder why.
Yo, that shirt looks stiff, dude. That shirt looks
Oh, really?
stiff.
Yeah. So what's that dating app called? Just out of curiosity.
Asking for a friend.
Right, just for a friend, yeah.
What's it called, sniff?
Anyways, check it out. Extra credit if you go back and report on your pheromone party. All right. So I'm gonna switch gears. Go ahead. The microscopes are already out. Grab some of the microscope slides and look at them.